online after the CE period has passed. So we will put this on the YouTube channel, but I just wanted everybody to know that this is going to be recorded. So we have some wonderful speakers today, and I just wanted to welcome everybody to the PGY2 Residency Research Programming Day 1. So hopefully everybody has signed up for all 3 days to listen to some great presentations. My name is Kelsey Zakauskas, and I am a solid organ transplant pharmacist at the University of Utah Health, and I am very excited today to moderate this session. Our objectives for today and all of the presentations we'll have over the next couple weeks are to compare and contrast Current Center practices with the information that you learned during these presentations, summarize the results presented during these presentations, and then assess opportunities for improvement at your Current Center with the information that is presented during these presentations. So one thing I wanted to point out for everybody is that the joint AST and ACCP research committee has created a research toolkit that is available to members in the AST COP hub and on the ACCP transplant PRN websites. Check it out for helpful information and tips on regulatory information, data management, and survey-based research. So if you want to check this out, there is a QR code on this slide for you to be able to scan and see these items. And then if you have any questions, reach out to Dana Pierce with more information. And with that, we will turn it over to the speakers to begin their presentations. Bear with us, it may take a little bit longer for the presentations today, so we may go a little longer than 4 p.m. Eastern Standard Time. So with that, I will turn it over to our first speaker, and this section will be on infectious diseases.
All right. Hello. So my name is Edith Ford. I am the solid organ transplant PGY2 resident at Mayo Clinic in Arizona. And this research project, we were looking at the impact of donor-positive blood cultures on solid organ transplant outcomes. Next slide, please. Maybe. Okay, there we go. Okay, so some quick background for this project. The reason that we wanted to conduct this project is that the impact of receiving organs from donors who have bloodstream infections or positive blood cultures is really unknown. There has been some data showing that overall there's a pretty low risk of transmission of the positive blood cultures to the recipients. Primarily, we see a higher risk with gram-negative organisms versus gram-positive organisms, and they typically occur pretty early, but there's no set guidelines or recommendations for the use of these. So whether patients need antimicrobial prophylaxis, what's the optimal duration and regimen to utilize. AST does have consensus guidelines stating that the recipients of organs from bacteremic donors should receive 7 to 14 days of targeted antibiotic therapy, but they do note in these guidelines that this is based on pretty limited data, and most of the studies looking at these have smaller population sizes and different results. So we wanted to conduct this study to see if we could potentially contribute to maybe more solidified guidelines. Next slide, please. All right. So again, some of the questions that we were hoping to address with the study is how long do we need antimicrobial therapies for patients receiving organs from donors with positive blood cultures, whether 7 days would be sufficient versus a longer duration, such as 14 days, and then whether we need antimicrobials for any positive blood cultures. So again, having that higher risk with gram negatives, can we potentially leave off antimicrobials for patients with lower, quote unquote, lower risk organisms? All right, next slide. Okay, so this was a retrospective single-center cohort study done at Mayo Clinic of Arizona. We included 199 solid organ transplant recipients from January 2019 to July of 2024 who received organs from donors that were reported through UNOS to have positive donor blood cultures, and patients were excluded if we didn't have any positive donor blood cultures. Next slide. Okay, so some of the baseline characteristics that we collected for the recipients and the donors. So for the donors, if they had positive blood cultures, we collected the date relative to transplant, what organisms were isolated, the number of positive blood culture bottles, and the donor cause of death. For the recipient, we collected obviously, if they had organs from donors with positive blood cultures, what organs were transplanted to include kidney, heart, pancreas, liver, or any combination, what surgical antimicrobial prophylaxis they received, and what antimicrobial therapy for the donor cultures they received, if any. And we determined what antimicrobial therapy they received for donor cultures depending on chart review or
No, but
indications on the
in there it
medication.
doesn't go because that's literally the dose that we will use for
Sorry,
another
can
organ.
someone
So,
mute them, please? And next slide. Okay. And so some definitions for clarity. So again, donor positive cultures were defined as any positive blood culture reported in the donor chart in UNOS within 72 hours of donation. We did also classify the pathogens between likely contaminants and true pathogens. So for the purpose of the study, a likely contaminant was any pathogen determined to be unlikely to be a true pathogen. And this is based on the pathogen virulence plus the number of bottles isolated, or if the culture was labeled in UNOS as a likely contaminant. So some examples are some common gram-positives like coagulase negative staph, if you have Cutibacterium species. So if these were only isolated in 1 out of 2 bottles, or if they were labeled as a likely contaminant, then we considered a likely contaminant. Otherwise, it was considered a true pathogen. Next slide. So the primary outcome of the study was the incidence of donor-derived infection within 60 days of transplant. While most of the donor-derived infections in literature is typically seen pretty quickly after transplant, we went with 60 days over 30 days just to make sure we were capturing any slow-growing organisms. While where there were a couple cases of Candida or fungal growth reported within 60 days. So we decided to capture 60 days just to capture anything. Secondary outcomes included patient and graft survival at 30 days and 6 months, the duration of antimicrobial treatment for positive donor cultures, if any, the incidence of likely contaminants in donor blood cultures compared to true pathogens, and then the incidence of C. diff infection within 60 days. Next slide. Okay, so for the baseline characteristics, as you can see, most of our patients received either kidney patients received either Campath or Simulect. Primarily, a lot of our liver patients received steroids only, and then we saw a few cases of thymo primarily in our heart population. Our most common transplanted organ was kidney, followed by liver. And then most patients received either cefazolin or ceftriaxone for surgical prophylaxis. Next slide. So some of the donor characteristics, as you can see, the most common organisms isolated were gram-positives and ones that we typically consider to be likely contaminants, such as coagulase negative staph, which was the most common, as well as viridin strep. And then next slide. There we go. So for the primary outcome of incidence of donor-derived infection within 60 days, so out of 199 patients, we had 2 confirmed cases of donor-derived infection, so overall rate of 4.1%, which matches a lot of the literature showing an overall low risk. For patient number 1, this was a liver transplant patient who had transmitted ESBL pneumobacteremia from the donor. The positive blood cultures were in the recipient were incidentally found on post-op day 1 because the recipient actually had pre-existing E. coli bacteremia unrelated to the donor's cultures that was discovered on a day 0 of transplant. Both bloodstream infections were treated successfully without any infectious symptoms. And actually the patient received treatment before the transplant team was aware of the donor cultures. For patient number 2, this was a kidney transplant patient who was transmitted, again, ESBL, E. coli bacteremia from the donor. This patient developed the positive blood cultures and necrotizing fasciitis in the abdomen immediately after transplant on post-op day 1. And despite receiving pretty broad spectrum antibiotic treatment and going back to the OR for washout, they unfortunately passed away on post-op day 2. So interesting to note that with both of these cases, they were both ESBL organisms that weren't covered by the perioperative surgical antimicrobial prophylaxis. And both of these cases occurred before the transplant team was made aware of the donor cultures. Next slide. Okay. So some conclusions from the study. So again, we showed that overall low rate of transmission matching what we have seen in the literature thus far. So 4% overall rate of transmission, so 2 cases out of 199, similar to the risks that have been reported with literature. So these were both gram-negative organisms, matching the literature that reports that the higher risk of donor-derived infection is seen with gram-negative organisms. And both of these cases had positive cultures immediately after transplant before they were able to initiate any targeted antibiotics. There was no statistically significant difference seen in the rate of transmission between 7 to 14 days of antimicrobial prophylaxis. And so, as we can see with the cases of donor-derived infection that we've seen, it seems that time to first antibiotic is more important than duration of antibiotics. Next slide. And so the results of the study kind of bring up the potential for overuse of antibiotics for donors with likely contaminant pathogens. And so one of the reasons that we wanted to look at the rate of likely contaminants versus true pathogens is to see if these patients, do they even need any antimicrobial prophylaxis at all? So about half of recipients who received organs from donors who had likely contaminants in their blood cultures received about a median of 8.6 days of antibiotics, which came up to a total of 249 days of potentially unnecessary therapy. And so as you can see, in all these patients receiving antimicrobial prophylaxis for likely contaminants, there was no difference in rate of donor-derived infection. So implying that for this patient population, they can potentially not require any antimicrobial prophylaxis. And if we do treat it, a shorter duration of 7 versus 14 days would be acceptable for this population. Next slide. And with that, I will happily take any questions.
Thank you so much for that great presentation. If anybody has any questions, feel free to pose them in the chat, but just stay muted. I'll give it about 30 more seconds. Oh, there's a question in the chat, Edith. It says, would you recommend broader spectrum empiric therapy for suspected DDI given the ESBL cases you identified?
That's a really good question, and I feel that's a potential slippery slope. Because I feel like if we do start broadening the coverage because we have those cases of ESBL, then that can be potentially, overuse of broad spectrum antibiotics. I think that's a question worth diving into. I would say just given the very low rate that we had in the study, I think that using broad spectrum targeted at potential resistant organisms may be overkill. And just I would say focusing more on if we have known donor cultures, making sure that the surgical prophylaxis is targeted at the known donor organisms. So potentially if we can try to make sure that we know any positive donor blood cultures before transplant would have the best outcomes.
Awesome. Well, thank you so much for your great question. And thank you so much Edith for a wonderful presentation. If anybody has any additional questions, feel free to put them in the chat and I will pass those along to the speakers or they can answer in the chat as we go throughout. So with that, we will turn it over to our next speaker.
Good afternoon, everyone. My name is Jonathan Boucher. I'm the current second-year ambulatory care pharmacy resident at VCU Health, and today I'll be talking about my project, letermovir for cytomegalovirus prophylaxis in solid organ transplant recipients. Next slide, please. One of our project members does have a disclosure to make regarding receiving research funding from Merck, but all other contributors have no conflicts of interest to disclose. Next slide, please. So, as you're all very familiar with, patients undergoing solid organ transplantation receive oftentimes universal prophylaxis, at least at our center, for CMV. The standard of care is Valcyte. However, the adverse effects, such as bone marrow suppression, can be dose limiting when it comes to our transplant immunosuppression agents like tacrolimus and mycophenolate. So letermovir, first FDA approved in June 2023 for de novo use in high-risk kidney transplant recipients by LeMay and colleagues, really is a attractive alternative as it doesn't have these adverse hematological side effects, but does have some moderate 3A4 inhibition that can lead to drug interactions with tacrolimus. Previously, before this was FDA approved, our group had looked into this and did a single center matched cohort study where we looked at breakthrough infections between letermovir and Valcyte or valganciclovir and saw no difference, but did see a meaningful change in tacrolimus trough concentrations, which led to the implementation of a protocol here at our center. Next slide, please. So our protocol allows for de novo use post-transplant in high-risk kidney transplant recipients or transition from valganciclovir for patients with intolerable leukopenias or neutropenias. Pending any insurance and benefits investigations or PAP applications, patients are initiated on letermovir with an empiric 40 to 50% dose reduction in their tacrolimus and rechecking these trough levels at 7 days after making this change for therapeutic drug monitoring. So after the letermovir was FDA approved, we wanted to go back and evaluate our protocol and look at how effective it was. Next slide, please. So we looked at patients who were on letermovir from November 2017 to December 2024, receiving it for primary prophylaxis, and we excluded patients who were on it for less than 28 days or had any positive CMV PCR prior to initiation. Next slide, please. This was a single center retrospective chart review that was IRB approved as a quality improvement project with data sources from Epic and Cerner EHRs. Next slide, please. So our primary outcome that we wanted to look at was CMV infection within 12 months post-transplant, which we defined as any positive PCR greater than 150 international units per milliliter. Secondary outcomes included breakthrough and resistant CMV infection, as well as changes to tacrolimus total daily doses and trough concentrations after letermovir initiation, changes in mycophenolate total daily doses, and changes in white blood cell counts after initiating letermovir. We also looked at patient and graft survival within 12 months. Next slide, please. We utilize mainly descriptive statistics, but we did look at changes in continuous variables using the Wilcoxon rank test. Next slide, please. Looking at our baseline characteristics, our average patient on letermovir was around 60 years old. About half the patients in this cohort were Black and half were white, mostly male. Mostly used in kidney transplant patients, over 80%. However, we did have a smattering of livers and hearts. Looking at their induction regimen, it lined up pretty well with the organ they received. So about 80% received antithymocyte globulin and about 20% receiving steroids alone. Looking at their CMV risk status, 2/3 were high risk and about 1/3 was intermediate risk. And looking at our kidney patients, their CPRA, the average patient in this study was not highly sensitized. Next slide, please. Looking at our primary outcome, 12 of the 45 patients had CMV infection within 12 months, so about 26.7%. This occurred a median of 60 days after letermovir discontinuation, which lines up well with what we see in the literature. The median viral load was about 3,500, but with a good spread there. 11 of the 12 patients required treatment, and 5 of the 12 required hospitalization for this. And there was 1 case of breakthrough and 1 case of resistant CMV infection. Next slide, please. Looking at tacrolimus outcomes specifically, 43 of the 45 were on tacrolimus at the time of the switch. 1 patient was on cyclosporine and 1 patient was on a CNI sparing regimen. Of these patients, about 1/3 were on immediate release and 2/3 were on extended release tacrolimus. An empiric dose reduction was made in about 60% of these patients and usually on the same day. And the time to the first level was about a week and time to second level was about 2 weeks. So pretty in line with our protocol. Next slide, please. Looking here at the changes in tacrolimus total daily doses and changes in trough concentrations, we can see that there was a statistically significant decrease in the tacrolimus total daily dose after letermovir initiation, about a 17% decrease. But while this decrease was made, we do not see a statistically significant difference in the trough levels, either at the first or the second check, but they do trend upwards, leading us to believe that this dose reduction still led to a trend towards increasing trough levels. Next slide, please. Looking at our changes in mycophenolate and white blood cell counts, the mycophenolate doses did not change at the first and second encounters after letermovir initiation. However, we do see improvement in white blood cell counts at both 7 and 16 days, leading us to believe that there may have been some improvement later on in the mycophenolate dose. Next slide, please. So looking at what we found, letermovir was safe and effective at preventing CMV infections in this cohort of solid organ transplant recipients. And an empiric tacrolimus dose reduction was required when initiating letermovir. And the 17% reduction led to a trend towards numerically higher tacrolimus trough concentrations at 7 days. Switching from valganciclovir to letermovir for CMV prophylaxis significantly improved leukopenia, which we did not see an improvement in the mycophenolate total daily doses, but may allow for future immunosuppression optimization. Next slide, please. Limitations. This is a single center retrospective chart review with a small sample size and lacking a comparator group, so we are limited in what we can draw from this. Next slide, please. I'd like to acknowledge my research advisors as well as our physician champion. Next slide. And I'm happy to take any questions.
Thank you for that great presentation. If anybody has any questions, feel free to put them in the chat and we'll give it about a minute. While we wait to see if anybody has any questions, I did have a question. Based upon your data that you found, do you think that you can do less of a dose adjustment to the CNIs when you start letermovir compared to the like 40 to 50%?
Yeah, that's a great question. Ultimately, when we look back at it, we believe that I think the number is probably somewhere in the middle there between that 40 to 50 and the 17, maybe around 20 to 30. It's hard to exactly to say because especially, half of or only 60% of these patients had that empiric dose reduction. So it's probably somewhere between 40 and 20, but not quite exactly sure where.
Thank you. All right, seeing no other questions in the chat, we're going to go ahead and move on. So thank you so much, Jonathan, for your great presentation. If anybody does have any questions for Jonathan, feel free to put them in the chat and he'll be able to answer those for you.
All right. Hello, everyone. My name is Daniela, and I'm currently the PGY2 Solid Organ Transplant Pharmacy Resident at Children's Healthcare of Atlanta. And today I'll be presenting on influenza vaccine uptake and effectiveness in pediatric and adolescent solid organ transplant recipients. Next slide. All right, these are the disclosures from one of our researchers that I won't go into for the purposes of time. However, our authors declare no conflicts of interest. Next slide, please. All right, so our objectives for today are to discuss current influenza vaccine recommendations among solid organ transplant recipients, Then we'll review the rates of influenza vaccination and complications of influenza infection among solid organ transplant recipients. And finally, we'll describe the influenza vaccine uptake and subsequent effectiveness among pediatric solid organ transplant recipients in this study. Next slide. So for non-solid organ transplant patients, influenza vaccination in pediatric patients was about 55% at the end of the 2023 to 2024 influenza season, which is the lowest pediatric vaccination rate in the past 5 years. During the 2023 to 2024 influenza season, 176 influenza-associated deaths occurred in the pediatric age group, and 80% of these patients were unvaccinated. Next slide. In solid organ transplant recipients, there is a higher incidence of influenza infection in the immunocompromised groups. And these may result in hospitalizations, acute rejection, graft dysfunction, and death. About 15% of pediatric solid organ transplant recipients had at least one hospitalized respiratory viral infection versus 4% of otherwise healthy children. Currently, 1 in 6 pediatric solid organ transplant recipients are hospitalized with a vaccine-preventable infection in the first 5 years post-solid organ transplant. And the risk of complications from influenza also appear to be higher in solid organ transplant recipients versus the general population, with the example of pneumonia. Next slide, please. So the annual influenza vaccination is the standard for prevention in solid organ transplant recipients greater than or equal to 6 months of age. However, solid organ transplant recipients have low influenza vaccine rates, with the most recently reported unvaccinated rate of 48% in the United States. Non-solid organ transplant recipients have comparable influenza vaccination rates, with a most recently reported unvaccinated rate of 45% in the United States. This recommendation of annual influenza vaccination is supported by multiple studies showing decreased influenza-related morbidity and mortality in vaccinated solid organ transplant recipients compared to unvaccinated solid organ transplant recipients. For example, one prospective study showed the receipt of the influenza vaccine in the same influenza season was associated with a decrease in disease severity as determined by the presence of pneumonia by 66% and a decrease in ICU admission by 51%. Next slide. So all the information presented guided us in the direction of this study. We wanted to determine how our influenza vaccination rates at Children's Healthcare of Atlanta compared to the national vaccination rates, as well as determine the efficacy of the influenza vaccine in the solid organ transplant population while on immunosuppression. Next slide, please. So this is a single center retrospective observational case control study. And we defined our influenza season as August 1st to July 31st for each year. So for example, August 1st of 2018 to July 31st of 2019. And we categorize our patients as unvaccinated if they received the vaccine within 14 days of an influenza diagnosis, or if they received the vaccine after influenza diagnosis. And we defined our patients as influenza positive if they had a laboratory diagnosis of influenza, such as a molecular test or via an antigen test. Next slide, please. So our primary endpoint was the rate of influenza vaccination among pediatric solid organ transplant recipients from August 1st to July 31st of each year. Our secondary endpoints were the influenza virus infection rates among the same population for our same window of time. Additional secondary endpoints were hospitalization due to influenza infection, treatment with neuraminidase inhibitors, ventilation status, as well as mortality. Next slide, please. Our inclusion criteria were patients 6 months to less than or equal to 21 years of age at the start of each influenza season. Patients also need to be a solid organ transplant recipient prior to the start of each influenza as be followed and seen by a transplant provider at Children's Healthcare of Atlanta. Our exclusion criteria were patients who were not seen by the transplant center during the influenza seasons, as well as patients were receiving treatment for acute allograft rejection, graft-versus-host disease, post-transplant lymphoproliferative disorder, or other cancers. And patients were also excluded if they had an allergy or contraindication to the influenza vaccine. Next slide, please. So the statistics utilized during the study are on the slide for reference, which I won't go into for the purposes of time. However, I will mention the last bullet, which is our vaccine effectiveness equation, which was calculated as 100% times 1 minus the adjusted odds ratio. Next slide, please. So for our baseline demographics, this represents data from across all 6 influenza seasons. So we had a total amount of patients of 1,054. The median age of our patients was 11.6 years, and the majority of our patients were of the male sex. About 42% were non-Hispanic white, and our organ percentage is as follows. So the majority of our patients were liver transplant recipients, followed by heart transplant recipients, then kidney transplant, as well as some patients who had multiple organs that were transplanted. Next slide, please. So the results for the influenza vaccine uptake are there on the slide for each influenza season, and the uptake ranged from about 68% to 70%. There were 321 influenza positive cases, so patients who got the influenza infection, and about 5,612 patients who did not get influenza, who are negative controls. Next slide, please. So influenza infection was found to be more frequent among those who were unvaccinated. So 91.9% who are unvaccinated versus 8.1% who are vaccinated. Vaccine effectiveness against influenza infection across all 6 seasons was 96.6%. And vaccine effectiveness across all 6 seasons for hospital admission was 58.8%. Next slide, please. So in conclusion, influenza vaccine decreased the risk of influenza infection and hospitalization due to influenza among pediatric solid organ transplant recipients for these influenza seasons. And future focus should be on improving and sustaining that vaccine uptake early in the influenza season. Next slide, please. These are the references I utilized. Thank you to my co-investigators. I'll be happy to take any questions you may have.
Thank you so much, Daniela, for that great presentation. If you have any questions, feel free to put them in the chat. There is a question. Is your institution planning any specific additional efforts to increase vaccine uptake next season?
That's a great question. And so from the results of this study, we'll be discussing them with a lot of our transplant providers and transplant coordinators. And so I think from discussing this with the rest of our transplant team is going to be a multidisciplinary approach and very team-based approach to continuing to try to increase vaccine uptake. Having our transplant pharmacists be involved in our clinic, especially giving vaccine recommendations and talking about vaccine hesitancy with our families, I think will be a really great help moving forward. It's something we've done in the past and something we continue to do and will continue to improve upon going forward.
Thank you. And another question, do you have any results for your secondary endpoints, such as mortality, treatment, or anything else?
Yes, those are great questions. And so didn't put them on the slides for the purposes of time. And so we did not have any patients that died from influenza infection in this study. And about half of our patients, or a little less than half of our patients, got treatment with an neuraminidase inhibitor. And the majority of those patients received also oseltamivir as their treatment.
Thank you.
Welcome.
Thank you for answering those questions. And again, great job on your presentation. We will go ahead and move on to the next speaker. Our next category is going to be infectious diseases, specifically in lung transplant.
Hi, my name is Alexander Aubin. I'm one of the current PGY2 solid organ transplant pharmacy residents at University Health in San Antonio. Today we'll be talking about the use of inhaled tobramycin for Pseudomonas eradication in lung transplant. Next slide, please. I have no disclosures, nor do any members of the study team have any disclosures today. Next slide, please. Objectives: by the end of this presentation, we'll have discussed overall outcomes in lung transplant and some of the consequences revolving around respiratory infection in the post-transplant setting. We'll talk about current practices regarding eradication of Pseudomonas, treatment of Pseudomonas respiratory infections. We'll have defined the successful use of inhaled tobramycin for Pseudomonas eradication in our patient population and our health system. And then we will have discussed the efficacy outcomes revolving around the use of inhaled tobramycin in this setting. Next slide, please. So in the setting of lung transplant, as we all know, being around lung transplant recipients, there is a much higher mortality rate compared to a lot of the other organs that we typically see transplanted. And much of this gets attributed to CLAD, or chronic lung allograft dysfunction, or infection. You can see both of those take up about half of mortality causes post-lung transplant. Next slide, please. Next, yeah, you can skip through these. So looking at post-transplant infectious outcomes, bacterial infections are the most pertinent. When looking at bacterial pneumonias, though, our most pertinent and most common organism is Pseudomonas. Next slide, please. Accounting for about 25% of bacterial infections that we see from a respiratory perspective. Next slide, please. So you can click through 3 times here. So we know with Pseudomonas infection, this elicits an immune response. And this immune response in literature has been shown to implicate the production of DSAs, or donor-specific antibodies, which may lead to both acute and chronic rejection. Thus, it is pontificated that Pseudomonas infection itself causes cell injury by activating lung fibroblasts and other aspects of the immune system to therefore go ahead and target the allograft. Next slide, please. So what do we do to treat this? Well, inhaled tobramycin is the most commonly used inhaled antibiotic, typically used in the setting of cystic fibrosis. Next slide, please. And we extrapolate a lot of our dosing schemes and strategies from the cystic fibrosis patient population. Next slide, please. Now, current literature really only exists in the setting of lung transplant recipients in regards to systemic exposure or toxicities. You can click through these. Next slide, please. So the clinical question that we're trying to ask today, the last slide was just a real quick PubMed search that showed that even in the setting of lung transplant recipients receiving inhaled tobramycin, there's really only a handful of studies, and all of those studies are really only speaking out on safety outcomes. So the clinical question that our study is trying to answer is if inhaled tobramycin works from an efficacy perspective for the treatment of Pseudomonas respiratory infection. And then we're going to kind of try to tease out a little bit of the confounding factors that might make somebody less likely to eradicate Pseudomonas or predictors of successful eradication in these patients. Next slide, please. So the purpose of the study, again, is looking at the success rate of inhaled tobramycin for Pseudomonas eradication. Next slide, please. Our study was a retrospective single-center cohort study that included adult lung transplant recipients between the years of 2020 and then April of this past year. We only looked at those patients that had Pseudomonas isolated in respiratory cultures and then were placed on inhaled tobramycin for eradication therapy. We excluded patients only if we did not have at least 6 months of follow-up. Next slide, please. So some definitions that we want to clarify. The 2 groups of patients that we're primarily comparing are going to be our successful and unsuccessful eradicators. So our successful eradicators are those that Pseudomonas was not subsequently isolated in respiratory culture within 6 months of that initial isolation of Pseudomonas. So this is presumed they're clearing the Pseudomonas or eradicating it after starting inhaled tobramycin, with unsuccessful eradicators being the opposite. So they continued to have microbiological presence of Pseudomonas. We also assess patients for recolonization. So after meeting criteria for successful eradication, if they regrew Pseudomonas after having a period of negative respiratory cultures, they were recolonizers. Then we looked at reduction in a maintenance immunosuppression, and this was defined by a decrease in tacrolimus troughs by at least 2, a reduction by at least half in our antimetabolite or progression of steroid tapering. Next slide, please. So our primary outcome is looking at the actual incidence of successful eradication, and then secondary outcomes are looking at the comparison between our successful and unsuccessful eradicators at the time points of 6 and 12 months, focusing on immunosuppression and antibiotic utilization, patient outcomes, and then renal respiratory function. Next slide, please. Next slide, please. So we'll discuss our results coming up here. So this is our baseline characteristics. Really, this is just showing that between our successful and unsuccessful eradicators, there weren't significant differences in age, sex, or any confounding factors that are typically implicated in increasing someone's risk of infection, like previous rejection treatment, retransplantation, hypogammaglobulinemia. But there was a statistically significant difference between patients that were bilateral lung transplant recipients versus single lung transplant recipients. Next slide, please. And you can click through these. So first, we wanted to look at the actual incidence of successful eradication. And at about 6 months, our cohort of 40 individuals had a 73% success rate. And then looking out to 12 months, that success rate increased to 84%. Next slide, please. Now, time to inhaled initiation of tobramycin differed significantly between the unsuccessful eradicators and the successful eradicators, with a median time to initiation of inhaled tobramycin being just 17 days in those that were successfully eradicating Pseudomonas. Next slide, please. You can click twice here. Now, we ran a regression analysis to, again, tease out some of those factors that could have made somebody more likely to successfully eradicate Pseudomonas. And really the only statistically significant factor that we identified was the time to initiation of inhaled tobramycin. So we found through a subsequent linear regression that was just looking at individual variables, that those that started tobramycin at an earlier point in time were more likely to be part of the successful eradicator group. Next slide, please. Then we also identified that more of the successful eradicators had reductions in maintenance immunosuppression looking out to 6 months, with about half of the successful eradicators undergoing reductions in maintenance immunosuppression, whereas none of the unsuccessful eradicators had any reduction in immunosuppression. Next slide, please. You can click through again. So this slide is a little bit of a busier slide. It just talks about some of the secondary outcomes that we looked at. Really, all I want to point out here is that there's no significant difference in renal outcomes or patient and graft outcomes when looking at the successful and unsuccessful eradicators group. But if you're looking at the middle there, where we're looking at respiratory outcomes, though not statistically significantly different, PFTs were grossly better in this successful eradicator group. Next slide, please. So study critique. This is the first study that at least has been published regarding the assessed efficacy of inhaled tobramycin in lung transplant recipients, albeit this is a small sample size at a single center and is retrospective, so it's hard to make any firm conclusions from this data. Next slide, please. So we did want to conclude, though, that Pseudomonas eradication is feasible with inhaled tobramycin. We did see a pretty good success rate at eradication in our patient cohort, but we did identify that with earlier initiation of tobramycin and reduction in maintenance immunosuppression, patients were more likely to successfully eradicate. Next slide, please. You can click through twice here. So some next steps. Our current protocol at our institution suggests the initiation of inhaled tobramycin at second growth of Pseudomonas. So we could start to consider maybe in certain patients earlier initiation of inhaled tobramycin in these patients growing Pseudomonas, or in certain patients where it becomes appropriate to purposefully reduce maintenance immunosuppression. This might be something that is more pertinent to do a little bit earlier. Next slide, please. And then I'd like to thank my colleagues and my mentors over the course of this research project. Next slide, please. And then we'll take any questions.
Thank you so much, Alex, for that great presentation. We did have a question in the chat. What was the average duration of treatment with inhaled tobramycin?
So our institution does suggest at minimum 28 days for like a start, and then we do the cycle on and off every 28 days. Now, we looked at median in our successful and unsuccessful eradicator groups, and it wasn't statistically significantly different, but on average, we're getting at least 2 cycles in our patients. So whether that be patients who did 2 cycles back to back for a total of 56 days, or if they did 1 cycle on, 1 cycle off, and then 1 cycle on again.
And then another question for you. Did you capture additional systemic anti-pseudomonal antibiotic exposure in these patients?
So we intended to assess these patients for systemic exposure by getting trough levels, but none of the patients in our cohort actually exhibited any signs of systemic exposure or nephrotoxicity, so none of them actually had any trough levels that were drawn. Now, the vast majority of literature out there is just looking at that systemic exposure, so with this not being the most pertinent part of our research project, it's not something that we worried about, but it would be something, if we were prospectively looking at this in the future, it would be something to at least gauge for academic purposes. Oh, for other anti-pseudomonal antibiotics. Yes, so there's a slide here that I didn't include just because it gets a little bit busy, but about 50% of our patients that were started on inhaled tobramycin were also concomitantly started on IV anti-pseudomonal antibiotics at that point in time. Now, going out to 6 months, all of those patients on IV or oral antibiotics at an index isolation, they had come off and about half of them still remained on inhaled tobramycin. So definitely it's likely that starting IV or PO antibiotics are going to encourage successful eradication, but it's hard to tease that out without a pre-specified protocol. So hopefully this research helps us show that inhaled tobramycin might be enough, that in the future we might be able to try monotherapy with inhaled antibiotics to see if this has a similar success rate to starting concomitant IV or PO antibiotics.
All right, thank you. And then there was another question about levels, but you mentioned those were not checked. Are you checking levels now for patients at all, or no?
We just check them in patients that we have concerns for nephrotoxicity. So none of the patients in our cohort had that, but we have a few patients that were not inside our cohort where we've checked levels. But we do start at the standard 300 milligrams inhaled BID.
Awesome. Well, thank you, Alex, so much for that great presentation. If anybody has additional questions, feel free to put those in the chat and Alex can answer those as we go throughout. So we will move on to our next presenter.
Hello, everyone. My name is Molly Gavin, and I am the current solid organ transplant pharmacy resident at Northwestern Memorial Hospital in Chicago, Illinois. Today I'll be presenting a study we conducted on the safety and efficacy of triazole antifungals in preventing invasive fungal infections and invasive pulmonary aspergillosis in lung transplant recipients. Next slide, please. And next slide, please. I don't have anything to disclose. Here are some abbreviations that I will use throughout the presentation. Next slide, please. So due to the significant morbidity and mortality of invasive fungal infections in lung transplant, antifungal prophylaxis is recommended. Invasive aspergillosis is also a risk factor for acute rejection and clad or chronic lung allograft dysfunction. The 2015 ISHLT guidelines recommend universal prophylaxis or preemptive therapy for protection against invasive fungal infections in lung transplant recipients. They do not recommend a specific mold active agent for universal prophylaxis, but do state that posaconazole, voriconazole, or isavuconazole may be used as preemptive therapy. Next slide, please. We currently have minimal data comparing the 3 antifungal agents that are mentioned in the ISHLT guidelines. There are 2 previous retrospective studies conducted in 2019 and 2022 that found no difference in efficacy between voriconazole versus isavuconazole and posaconazole versus voriconazole, respectively. The 2019 study did find isavuconazole to have better tolerability overall in respect to adverse drug effects compared to voriconazole. And other studies have also found less hepatotoxicity and QTc interval prolongation with isavuconazole compared to posaconazole or voriconazole. However, when looking at all 3 agents, there are no known studies to date that compare both the safety and efficacy of these agents for invasive fungal infection prevention after lung transplant. The Purpose of our study was to assess the safety and efficacy of these antifungal agents in the prevention of invasive pulmonary aspergillosis post-lung transplant. The primary endpoint was kind of divided into two parts. So the first part of the primary endpoint was the incidence of breakthrough fungal infections, and then the second part is the incidence of invasive pulmonary aspergillosis within 3 months of prophylaxis withdrawal. Secondary endpoints were adverse drug effects attributed to antifungal prophylaxis, the incidence of CLAD, and the incidence of biopsy-proven acute cellular rejection. Next slide, please. We conducted a single-center retrospective chart review study that included adult lung transplant recipients from the beginning of 2022 to the end of 2023. We excluded multi-organ transplants, retransplants, and those that were on antifungal therapy at the time of lung transplant. And you can see on the right here, so we resulted in a total of 92 patients that met inclusion criteria. And of those, 62 patients received posaconazole, and 15 received voriconazole, and 15 received isavuconazole. Next slide, please. At our institution, our standard induction is with methylprednisolone and basiliximab, and our maintenance immunosuppression is listed here as well. For antifungal prophylaxis, we practice universal prophylaxis with posaconazole as the preferred agent, dosed at 300 milligrams daily, and we initiate it on post-op day 1 and continue it for a minimum of 6 months after lung transplant with a target prophylaxis trough of greater than or equal to 0.7. However, we have noticed that voriconazole and isavuconazole have also been used for prophylaxis in recent years for various reasons, including QTc interval prolongation and hepatotoxicity. Next slide, please. Thank you. So moving on to our results, we found that baseline characteristics did not differ significantly between the 3 different antifungal cohorts. Majority of patients were of white race and received bilateral lung transplants, and the median age was 65 years old. At the bottom of the table on the right here, you can see that we collected receival of complement inhibiting or anti-lymphocyte therapy. These may be given perioperatively for those at a high risk of antibody-mediated rejection or AMR, such as those that are highly sensitized or have a positive cross-match, or patients with donor-specific anti-HLA antibodies. We found that a higher percentage of patients in the isavuconazole arm received eculizumab and anti-thymocyte globulin, followed by voriconazole. However, this was not statistically significant. Next slide, please. So when looking at the first part of our primary outcome, you can see this table here. On the y-axis, we have displaying the percent of patients, and then on the x-axis, we have the different antifungal agents. So our study found that the highest percentage of breakthrough fungal infections occurred with voriconazole and isavuconazole, and the least with posaconazole. However, this was not statistically significant between the antifungal agents. Next slide, please. And with the second part of our primary outcome, so it also revealed that significantly more patients in the voriconazole group experienced invasive pulmonary aspergillosis within 3 months of prophylaxis withdrawal compared to posaconazole and isavuconazole, and this was statistically significant. Next slide, please. Moving into adverse drug effects, so we analyzed this as part of our secondary endpoint. So we found that 42% of all patients experienced an adverse drug effect contributed to antifungal prophylaxis, with voriconazole having significantly more. Across all agents, we found the most common adverse drug effect was altered mental status, which most commonly occurred with voriconazole, and then hepatotoxicity was seen most commonly with posaconazole. Next slide, please. The remainder of our secondary endpoints revealed that CLAD was seen more often in patients receiving voriconazole, but this was not statistically significant. We know that invasive fungal infections is an independent risk factor for CLAD and may have contributed to the higher rate of CLAD seen in those on voriconazole. And then biopsy-proven acute cellular rejection was observed most frequently in those on voriconazole, followed by posaconazole, and this difference was significant between the antifungals. Next slide, please. Limitations of our study included its retrospective nature and the requirement for manual chart review for data collection. And additionally, the small population size of 92 patients was another limitation. However, this size is comparable to similar retrospective studies. Follow-up time, so our data was only analyzed up to 1 year post-transplant, and longer-term outcomes and survival were not assessed. And then finally, some patients were limited for alternative antifungal prophylaxis due to insurance coverage. Next slide, please. So in conclusion, there is a paucity of data available to compare posaconazole, voriconazole, and isobuconazole for invasive fungal infection prevention following lung transplant. This study observed no difference in breakthrough fungal infections between the agents analyzed. We found an increased number of invasive pulmonary aspergillosis infections to occur after voriconazole withdrawal, as well as more adverse drug effects occurring with voriconazole. So ultimately, prospective studies are needed to compare these antifungal agents as the use of isobuconazole increases within clinical practice due to a more favorable adverse drug effect profile that we have seen in current literature. Next slide, please. I'd like to thank my research team for their contributions, and I am happy to take any questions. Thanks for your question, Edith. We routinely monitor posaconazole and voriconazole levels to guide dosing. So for posaconazole specifically, we will start at the dose of 300 milligrams daily. And if we do not achieve our goal prophylaxis trough concentrations by steady state, then we will increase the dose from 300 milligrams daily to 200 milligrams twice a day, and then reassess once that obtains steady state. We did record all levels for voriconazole and posaconazole. Once they achieved our goal prophylaxis trough, we use 1 for voriconazole. And then for isobuconazole, we do not routinely obtain levels. We did get it on 1 patient per chart review. It looks like the purpose of that level was to assess for absorption, but we do not routinely monitor for isobuconazole. Thank you. Kelsey, I'm not sure if I think you're muted still.
Oops. Okay. Thank you so much, Molly, for that great presentation. And if you have any additional questions, please feel free to put those in the chat. And we will move on to our last presentation, which will specifically be on lung transplant.
Hi, everyone. My name is Emily Graves. I'm currently the PGY2 transplant pharmacy resident at Ohio State. And today I'm going to be presenting my research project on assessment of risk factors and outcomes of leukopenia in lung transplant recipients. Next slide, please. I have nothing to disclose. Next slide. So for some background, leukopenia, it's quite common after transplant and often leads to changes in immunosuppression and antimicrobial prophylaxis. And there's very little research available for risk factors for leukopenia, especially in the lung transplant population. Next slide. So the purpose of our study was to identify risk factors for developing leukopenia within 6 months after lung transplantation. Next slide, please. This was a single center retrospective case control study that took place between January 1st of 2013 through August 31st of 2023 at Ohio State. And we defined leukopenia for this study as a white blood cell count less than 3,000. Next slide. We included patients 18 to 89 years old that were transplanted within the study time period. We excluded incarcerated patients, lung retransplantation, and leukopenia at the time of transplant. Next slide, please. Our primary outcome was to identify risk factors for the development and time to leukopenia within the first 6 months after lung transplantation. Again, leukopenia was defined as a white blood cell count less than 3,000. Secondary outcomes looked at medication changes due to leukopenia, mortality at 1 year post-transplant, incidence of rejection within 1 year post-transplant, infection incidence within 6 months post-transplant, and administration of granulocyte colony stimulating factors within 6 months post-transplant. Next slide. During the study timeframe, 471 patients were transplanted. We excluded 24 of those transplants, primarily due to them being a retransplant. So overall, we had 447 patients in our study. 211 of those patients developed leukopenia within 6 months after lung transplants, and 236 did not develop leukopenia. Next slide, please. So looking at risk factors that we identified for leukopenia, just to orient everyone to the slide, on the left-hand side, we have the variable, and then the leukopenia percentage column in the middle is the percentage of those patients that had that variable that developed leukopenia. So for example, for type of transplant, 51.6% of patients that had a bilateral lung transplant developed leukopenia compared to only 33.3% of patients that had a single lung transplant. So significantly more patients that had a bilateral lung transplant developed leukopenia. Those that were acutely hospitalized prior to transplant, which we defined as being admitted greater than 48 hours prior to transplant. Those that had ECMO within 7 days pre-transplant were more likely. And then those that received renal replacement therapy post-transplant were also more likely to develop leukopenia. Next slide, please. CMV serostatus risk, those that had high and intermediate risk were more likely to develop leukopenia compared to those that had low CMV serostatus risk. Patients with a treated CMV infection, 91.7% of those patients developed leukopenia. And then CMV prophylaxis at index discharge, those that were discharged on letermovir were more likely to have leukopenia, likely because they developed leukopenia during their index admission and were at that time switched from valganciclovir to letermovir. Next slide, please. The average time to transplant to leukopenia was 69 days, and the average duration of leukopenia was 7 days. And 62.6% of patients that did have leukopenia did have recurrence within the 6 months of transplant. Next slide, please. Looking at medication changes in the leukopenia group, 75.8% of patients did have a medication change due to the leukopenia. The most common change was to the mycophenolate in 70.6% of patients, and that was either holding doses of mycophenolate or reducing doses. Azathioprine was changed in 4.3% of patients. For CMV prophylaxis, 29.9% of patients had their CMV prophylaxis modified. In more recent years, it was more so switching to letermovir, but in the early time frame of the study period before letermovir was available, a lot of patients were switched to preemptive monitoring. And then PJP prophylaxis was changed in 10% of patients. Next slide, please. Looking at mortality and rejection within 1 year post-transplant, we did not see any differences between the groups. We did see more infection in the leukopenia group within 6 months post-transplant, and that was primarily driven by bacterial infections. And then granulocyte colony stimulating factor used within 6 months post-transplant was used in 38.9% of patients in the leukopenia group. Next slide, please. So overall, we did find several risk factors for leukopenia post-lung transplant, including bilateral lung transplant, hospitalized prior to transplant, ECMO, renal replacement therapy, and CMV serostatus and CMV infection. Patients with leukopenia were more likely to have an infection within 6 months post-transplant, but we didn't see any differences in rejection or mortality at 1 year. So overall, we do need more research to evaluate the long-term effects of leukopenia on lung transplant outcomes. Next slide, please. And with that, I will take any questions that you all have.
Thank you for that great presentation, and thank you everybody for sticking around to hear all of these great presentations. If you have any questions, feel free to put those in the chat. Otherwise, I added my email address and you can feel free to send me any questions and I will forward those on to the appropriate speakers. And as we are getting ready to see if there are any questions, I just wanted to thank you all for attending again, and then be looking out on your email for an email from me regarding how to obtain CE credit from all of these presentations. And again, we hope that you will continue watching this series. We have our next one on May 13th, and then our one following that on May 20th. So please sign up for those if you have not already, and have a great afternoon.